there were 1.3 million hospitalizations here in the United States in 1 year. And it's the #1 diagnosis for readmissions within 1 month. And it's projected that we will have a rise in heart failure of 50% over the next 25 years. And so what is the definition of heart failure? The definition of heart failure by the American College of Cardiology and the American Heart Association, which is the societies that I am part of. The diagnosis of heart failure is a complex clinical syndrome with symptoms and signs that result from any structural or functional impairment of ventricular filling or ejection of blood. So if your lungs and your brain and your liver and your kidneys are not getting enough oxygen from blood pumping, and you feel like you're not getting enough blood, that is the definition of heart failure. And there's actually two different types of heart failure. One is there's actually four, but there's two major ones: the first line and the last line. And so the first line is heart failure with reduced ejection fraction. And ejection fraction is the amount of blood that's pumped out with each beat. So if the heart is not pumping well and it's weaker, we call that reduced ejection fraction. And so there's a reduced ejection fraction type heart failure, and then there's preserved ejection fraction type heart failure. And that's where the blood is actually, the heart is pumping correctly, like it's squeezing correctly, but it's still not allowing enough blood to get everywhere. And that is a result of stiffness of the muscle. So the muscle gets stiffer and stiffer. The heart beats about 100,000 times a day. It's been doing that since we were born. And so that's a lot of heartbeats. And just like any other muscle, like a leg muscle or a arm muscle or a shoulder muscle, after use, it gets a little bit stiff. And this stiffness doesn't allow enough blood to get in before the next pump. And so that's what preserved ejection fraction is. But sometimes people could have like heart attacks, like our neighbor Jack, and that reduces the amount of blood that can be pumped per pump. And so there's two big major types. And in women and men, there's a little bit of a difference. And in women, there's a little bit more heart failure with preserved ejection fraction. But in men, it's about equal, about 28% each of preserved ejection fraction and reduced ejection fraction. The prevalence of heart failure increases as we get older. So when we were 20 to 39 years old, the prevalence was 0.3%, so maybe 1 in about 300. By the time we are 80, it's 10%. So 1 in 10 people have heart failure. And so it's what we do to our bodies, but it's also just a product of aging. Our aging causes some amount of heart failure. And so these are the major risk factors for heart failure: age being one of them, smoking, diabetes, high blood pressure, obesity, atrial fibrillation, myocardial infarction, which is heart attacks, and a few other heart issues. And so these are the major risk factors causing heart failure. So, heart failure. So in heart failure, the mean survival, meaning the average amount that you live for once you've been diagnosed with heart failure, changes with age. So at 65, the mean survival of an average 65-year-old is 18 years. At 90 years old, the mean survival is 5 years. But if you have heart failure, the mean survival is at 65 years old is 4 years. And at 90 years old, the mean survival once you've been diagnosed with heart failure is about 1 year. The amount of hospitalizations have been going up with time, as you can see in this graph. The amount of preserved ejection fraction hospitalizations and the amount of reduced ejection fraction hospitalizations are about equal. The reason why it's very yellow here is because we're actually diagnosing preserved ejection fraction a lot better these days. And so it's probably been about equal over time. And in 2018, you can see the preserved ejection fraction hospitalizations and the reduced ejection fraction hospitalizations are about equal. So once you've been hospitalized for heart failure, the chance of death after being hospitalized from heart failure at 4 years is about 80% chance. It's a lot more than any other disease. For example, coronary artery disease, it's probably about 10% of, like, even if you've had a heart attack, the survival is about 10 times better than heart failure. So heart failure is a major impact for how long people live with heart failure in hospitalizations. And so there's a lot of things. So we talked about the different risk factors for for heart failure. And so those are high blood pressure, diabetes, abnormal cholesterol, obesity. And these cause different kinds of mechanisms of damage to the heart. But basically what it comes down to is when our heart starts to get older and into just a little bit of heart failure, what our body tries to do, there's a natural reaction of our body. And back when we were being chased by saber-toothed tigers, what happened was if we got bitten by a saber-toothed tiger, our body tried to compensate. And to compensate, what it would do is it would trigger the fight or flight mechanism. So this fight or flight mechanism helps us to stay alive with saber-toothed tigers chasing us and biting us. But our body, as we get older, thinks, so when the heart starts pumping a little bit less, it starts thinking that we're being chased by a saber-toothed tiger. And it increases the fight and flight hormones and the neurochemicals. And so what that does to our heart is it makes our heart work harder. So it's back in the 80s, the cardiologists and scientists thought if you could make the heart work harder, then people would live longer. So they started back in the 80s, they started everybody on a medication called digoxin. You know, Romeo and Juliet type of digoxin, digitalis. But this digoxin helps the heart pump a little bit harder. And so we put everybody on digoxin back in the 80s. And what we found with the research here in the United States was people died more on digoxin. And so we were actually doing the exact opposite of what we should have been doing. And what we found out since then is that what we need to do to try to get these heart failure patients better is to try to reduce the fight and flight type hormones and neurochemicals. And so all of the medications that we have come up, that we've found works, helps to fight in this fight or flight type of mechanism. There's also natural things that we can do, such as eat healthy, exercise. Those are the kinds of things that help in heart failure. Low salt intake. But the medications that we use is all about reducing this fight and flight reaction of our bodies. And so that encompasses our kidneys, it encompasses our blood vessels, it encompasses the brain, it encompasses the neurologic system. And so what we're trying to do is we're trying to block this fight and flight mechanism everywhere. And what we found is people live longer and people are hospitalized less when we do this. And so we now have 4 medications for heart failure. For reduced ejection fraction, there's 4 medications. For preserved ejection fraction, there's 3 medications. And so this is showing us with reduced ejection fraction, back when we had only 2 medications. So when we look at these research articles, when there's a line of unity at 1. And so the line of unity at 1 means nobody's dying more or surviving more. And so if you see these error bars come and overlap, then that means we're not sure if it's really helping or not. And so you want these error bars to move away from this line of unity. And so in this graph, when things go more towards the left, such as right here on top, it means people are surviving more. So this is with the medical treatments that we have, people are surviving more. And so over time, what we found is with the medications that we use, so we have ACE inhibitors, ARBs, which is angiotensin blockers, and then we have beta blockers, and then we have mineralocorticoids, and then we have much newer medications like SGLT2 inhibitors. We'll talk about these. But when you start putting these in combination, what we found is people are living longer and we're having less symptomatic heart failure. And all these medications are trying to block this fight and flight kind of mechanism. And so over time, so over the last 20 to 30 years that we've actually had these medications, we have done a more effective job of preventing hospitalizations and deaths. Back when we had one medicine, it was slightly, and over time, it has become much better. And so when we talk about heart failure, I'm just showing these slides because I'm going to show you some research, and they all talk about stages and New York Heart Association classes. And so stages there's 4 stages of heart failure. And stage A is people that don't have heart failure, but they're at risk of being heart failure. That's considered stage A. Stage B is pre-heart failure. That's people who do have heart failure, but have no symptoms. Stage C is symptomatic heart failure, and stage D is advanced heart failure, very severe heart failure. And then we also have a classification called the New York Heart Association functional class. And this functional class 1 is no limitation, 2 is slight limitation, 3 is marked limitation, and 4 is unable to carry on physical activity without symptoms of heart failure or heart failure at rest. So in stage A is you don't have heart failure, but you have risks only. The treatment is control the risk factors. And so those are controlling blood pressure, cholesterol, diabetes, having people exercise more, have people eat more healthy. That's the treatment for stage A. But once you start getting to, so that's this, is trying to treat the underlying things in stage A. At stage B, you actually have a heart that is starting to fail, but no symptoms. And when you have that, the American Heart Association and the American College of Cardiology recommends basically only 2 medications. So the 2 medications are ACE inhibitors or ARBs. These are common blood pressure medications that we use, and a beta blocker. So there's 2 medicines. And so ACE inhibitors and angiotensin receptor blockers, it helps improve mortality and morbidity. And it's a class effect, meaning you can use any ACE inhibitor or ARB, and it's going to be effective compared to beta blockers, which is not like this. And so we usually start with an ACE inhibitor. And then if there are any side effects, then we go to an ARB. And the higher the dose, the more we have found that is more effective towards heart failure. And then beta blockers helps improve mortality, and there is no class effect, meaning not all of the beta blockers help with heart failure. There's only been 3 medications that we found help with heart failure in beta blockers, and they are carvedilol, metoprolol succinate, and bisoprolol. And again, the maximum dose tolerated is what we found helps with heart failure the most. So once we start getting to stage C or D, this is symptomatic heart failure, there's more medications that are recommended. So back even 10 years ago, when I first came here as a cardiologist, for heart failure, we only had beta blockers and ACE inhibitors. So there were only 2 medications. Now there's a lot more medications, and so I feel really bad because when a patient comes into the clinic with new onset heart failure, I tell them, you have to take a whole bunch of medications. There's 4 or 5 medications you have to take if you have heart failure. That's a lot. I feel like I'm being sponsored by the drug industry, but we found that it works. And some of these are expensive too, because the newer ones, you're seeing them all on TV. And if you're seeing them on TV, then that means it's expensive and they're making a lot of money off of it. But we found that it helps save lives. And so that's why, even though I don't like being on medications personally, if you have heart failure, then you should be on multiple medications to try to save your life. So there is a new class of medications called angiotensin receptor neprisilin. also known as Entresto. And so you could either use that or an ACE inhibitor, ARB. You can use only one or the other. And then there's beta blockers we talked about. And then mineralocorticoid receptor antagonists, which is spironolactone. It inhibits a hormone called aldactone, which is part of that fight and flight kind of cascade. The latest medication is called an SGLT2 inhibitor. It's a sodium glucose transport 2 inhibitor. It's a diabetes medication, actually. We'll get to that. And then diuretics as needed. So there's multiple diuretics that we use. And the dosing, the milligrams is different for everyone. And so because you're on 40 milligrams of furosemide, it's not equal to 40 milligrams of the other medication. And so there's a starting dose and there's a maximum dose. There's also these diuretics called thiazides, like hydrochlorothiazide. It's a very common diuretic. If you use furosemide and thiazides together, it can cause electrolytes disturbances, azotemia, which is a disturbance in acids, acid and bases. So we reserve that for people that, because it works really well if we put people on multiple diuretics, but it can cause multiple issues. So we have to be aware of this. It can cause low potassium, low magnesium, low sodium, and acid-base disturbances. And then if you need a diuretic and the diuretic isn't working, it may be that you're on too low of a dose. And so we start increasing the dosage. And so we can double it, triple it twice a day, switch it to another diuretic, add a thiazide, and if that doesn't work, we'd have to hospitalize you for IV medications. So, in addition to diuretics, which is addressing the volume overload, there's 4 pillars of heart failure now in reduced ejection fraction type of heart failure. And they, again, are beta blockers, ARNIs, ACE inhibitors, ARBs, which is the ARNIs are relatively new, mineral receptor antagonists, and SGLT2 inhibitors. So the SGLT2 inhibitors, well, we'll get to that later. Okay, so the first medicine that they researched was carvedilol, Choe. And so this was a study done in 2002. It was published out of Mayo Clinic. And what they found was that in patients with reduced ejection fraction heart failure with an ejection fraction of less than 25%, it reduces mortality by 35%. And it reduces deaths and hospitalizations by 24%. And so when we look at these research articles, there's a p-value, and p-value tells you whether science thinks this is a significant enough difference. And in science, we consider a significant difference if the p-value is less than 0.05. Less than 0.05. And so for mortality, they reduce mortality from 19% down to 12%. And so the relative reduction was 13% or 35%. And the p-value was significant because it was 0.00013. So the significant value is 0.05, p of 0.05. So this was very significantly statistically different. Same with deaths and hospitalizations, reduction of 24% with the p-value of 0.00004. So much less than 0.05. The next medication that was studied was ACE inhibitors. And so the ACE inhibitor that was used was enalapril in low ejection fraction. So the ejection fraction was less than or equal to 35%, New York Heart Association class 2 or 3, comparing placebo versus enalapril. And the mortality difference was 39% versus 35% with the p-value that was significant, less than 0.0035. And then deaths and hospitalizations was reduced from 57% down to 47%, significant p-value. Deaths reduced from 35% down to 31%, significant value. So that's why these were old studies. So this was a 1991 study. The other was a 2002 study. These are old medications, but we found that they do help with deaths and hospitalizations. And so we've had these available for about 20, 30 years now. Entresto is the new medication, and it's a medication that inhibits enzyme neprisilin, which is responsible for degrading BNP. BNP is a hormone that our heart uses. And this BNP helps to improve the heart function. So it actually helps decrease that fight and flight mechanism. And so there's two medications in Entresto, sacubitril and valsartan. And we think that this BNP helps decrease neurohormonal activation, vasodilation, cardiac fibrosis, hypertrophy, and it's a natriuretic, meaning it's a mild diuretic. And so this study was a more recent study, published in 2014. And in this study, they compared Entresto to enalapril with the New York Heart Association class 2 to 4 with an ejection fraction of less than or equal to 40%. And what they found was cardiovascular deaths and hospitalizations were reduced from 26% down to 21% with a p-value of 0.01, so that's less than 0.05. And so this was statistically significant, and it was found to be better than just using an ACE inhibitor. And then it also helped reduce deaths. It helped reduce hospitalizations, all significant p-values. And so that is why now if you go to Desert Cardiology Center and see one of our cardiologists, and if you have heart failure, we are using more Entresto and less of the ACE inhibitors such as benazepril, enalapril, or ARBs, which is like losartan and valsartan. This one is advertised on TV a lot. You know what that means? So we avoid Entresto if there's history of angioedema, which is swelling, and it can lower blood pressure a lot. So watch for low blood pressure, and it's also a mild diuretic. You hold an ACE inhibitor 36 hours prior to the initiation of Entresto, and there is manufacturer financial assistance. So there was another study. This one was published in 1999. So it's sort of an old study. And this one compared spironolactone to placebo in reduced ejection fraction of less than or equal to 35%, New York Heart Association class 3 and 4. And the trial was discontinued early because it was such we found such a big difference between treating the patient with spironolactone and placebo. It helped decrease deaths from 46% down to 35%. So a relative reduction of about 30% risk of deaths with a significant p-value of less than 0.001. It reduced hospitalizations with a relative risk reduction of 35%. And the only problem, it causes gynecomastia, which it means it enlarges the breasts. And so men only seem to have this side effect problem, and only men seem to complain about this. And the prevalence is about 10%. So we do not use this medication if the kidney function is abnormal. We do not use this if the potassium is too high. We recommend a low potassium diet. And if we do have this weird side effect of gynecomastia in men, we switch to a more expensive medication. Spironolactone is really cheap, but eplerenone is a lot more expensive. And so we switch people over to this more expensive medication. And this is the dosing for spironolactone and eplerenone. Okay, sodium glucose transport 2 inhibitors, SGLT2 inhibitor. This is the newest of our heart failure medications. And this medication is a diabetes medication. It helps to block the transport of glucose in this thing here. Does anyone know what this is? It's called a nephron. It's in the kidneys. And this is the single unit of filtration in the kidneys is called the nephron. So the blood goes into this glomerular part of the nephron, and the kidney filters out everything it needs to filter out into these tubules, and this tubule eventually goes into the kidney and eventually into the bladder and eventually into the toilet. So as it's filtering things out, it reabsorbs certain things that it wants back, like, for example, sodium and the acid bases. It tries to filter out the right amount. And so there's a lot of filtration going on in the proximal and distal tubules. But in the proximal tubule, which is this one, there is a sodium glucose transporter. And so this is one of the parts of the kidney that help to regulate glucose being filtered out. And our body does not like any glucose to be urinated out. That's how our kidney was built. And so people with diabetes, when their glucose level is too high in the body, we start dumping out glucose into the urine. Well, this medication increases that amount of glucose dumping out into the urine. And so even patients without diabetes, we recommend this diabetes medicine because it helps save lives. And we notice high amounts of glucose in the urine. And so the major side effect of this medication, because there's glucose in the urine, is it can cause increased urinary tract infections, especially in people that have urinary leakage issues. And I read weird case report even of this one patient who kept on getting he had to do drug tests for some company, and they were consistently finding alcohol in his urine, but he wasn't drinking. And what they found was this company kept the urine in room temperature for a day before being tested. And this guy had a urinary tract infection where the bacteria was creating alcohol in the urine because this guy was on this medication. And so he tested positive for alcohol 4 times because the body, the bacteria were making alcohol outside of the body in the test file. But anybody that has leakage, especially, could get increased urinary tract infections with this. And how does this help with heart failure? We're not sure. We don't know. How does urinating out more glucose help with heart failure? It may be diuretic because when you have glucose, you have to urinate out more fluid. So it may have some diuretic effect, but we think that there is some type of anti-inflammatory effect of this medication. But we're not completely sure. But we know that it helps. How do we know that it helps? Because we did a trial, and these trials, it started out as diabetes trials, and what they found was people that had heart failure in these diabetes trials, they were doing much better than people that didn't have heart failure. And so finally, they did a study in patients that didn't even have diabetes and just had heart failure. And so, they had and did not have diabetes, but they didn't select out for diabetes. And so they put people on a medication called dapagliflozin. That one is, I believe, Jardiance. And so they compared placebo with Jardiance with an ejection fraction of less than or equal to 40% in New York Heart Association class 2 to 4. And there was a 26% reduction in deaths and hospitalizations. There was about a 18% decrease in deaths. And this finding was similar in diabetics and non-diabetics. And so after this study, we have approved a fourth medication that helps with deaths and hospitalization. So Lasix is not a medication that helps with deaths and hospitalizations. Lasix is used just to help people feel better because they're fluid overloaded. But these other four that we talked about, they do help with deaths and hospitalizations. And what I have seen in my clinic is people that do have heart failure that we put on these medications that do well with not eating too much salt and eating healthy and exercising, they do very well. And so this statistic of 80% deaths in 4 years after the hospitalizations, I think we can do better. And I think we do better with the medications. But at the same time, nobody lives forever. And so that's sort of the limit that we're heading towards. My grandma lived to 102 years old. I wish I lived to 102 years old, but I don't know. That's the mystery of life, and we don't know how long we're going to live for. But our goal as cardiologists is to try to get to people to live as long as possible. And so we try that. And with these medications, eating healthy, exercising, I think we do a good job. and we can live longer and feel better and be less hospitalized with medicines. But I still do feel bad because I tell them you have to be on 4 or 5 medications, which does not feel right when I tell them you have to be on 4 or 5 new medications when somebody comes in with new onset heart failure. But that's what the research shows is the case. A similar study showing the same thing with another SGLT2 inhibitor. And so as we start this, they all help reduce deaths and hospitalizations. In preserved ejection fraction, instead of 4 medications, so this is 1, 2, 3, 4, not the diuretics, because the diuretics is not for deaths and hospitalizations. There are medications recommended, but the green is class 1, meaning we know that it helps a lot, and the studies show that it helps a lot. The class 2A and the class 2B recommendations by the American Heart Association means that it does help some, but it doesn't help as much. And so people with preserved ejection fraction, they don't respond as well to medications, but we do start these medications because we're trying to keep people living as long as possible if we can, even though the data doesn't show that it's as helpful as in reduce ejection fraction. But we do this to try and it helps with decreasing hospitalizations, and we're just trying to keep people feeling good and living as long as possible, in addition to all the natural things such as eating healthy and exercising. And so that is the end of my lecture. Thank you.
Questions?
So we'd like to open it up to questions here in the audience, and do you have any in the chat room?
We do. Whoops. Yeah, we do have them in the chat. How does what is it? I'm just saying it's very small. Arterial sclerosis mesh with heart failure?
Atherosclerosis is coronary artery disease, basically in the heart. And coronary artery disease can cause heart attacks and increase inflammation. And so it does increase the risk for heart failure. And so in those patients, there's more specific treatments for coronary artery disease, which is helping reduce plaque accumulation with statins. If you need a stent or bypass, we do that sometimes. And so, yes, it is associated, and we treat that separately optimally. But in terms of the heart failure medications, they're completely separate heart failure medications.
Hello? Hello?
Yes, we can hear.
I want to thank you. I felt like I was in 8th grade algebra again. There are a lot of abbreviations there. But when I visit people in the hospital, I get CHF, by their names from the nurses, 4, 5, 6 people. Every one of those people, they don't have common symptoms. If you go in for AFib, you know, they have a high heart rate. They have a pacemaker, it's beating slow, but congestive heart failure seems to be all over the place.
Yes, that is absolutely correct. And that is also true with angina. People with coronary artery disease, their symptoms are very different. Women's symptoms are different from men's symptoms. And then even in heart failure, the symptoms are different. And so if we were like a Ford F-150 and we knew exactly what was wrong, it would be much easier. But that's not how medicine is. Medicine is practice of medicine because everybody is so different. Our bodies are not exactly the same, like a Ford F-150 is exactly the same to another Ford F-150 that was made. And so since the bodies are different, and since the the way people react to nature and medications is different, everybody is different. And so you're right. It is tough to diagnose, and so it takes skill to sort of figure out.
Yes, my question is, congestive heart failure kind of a general term?
Yes and no. The definition comes down to the same, where you're not getting enough delivery of blood and nutrients to the body. And depending on how that happens in the body, the symptoms are different.
Thank you very much, Doctor, for coming tonight. My question is, could you tell us some of the signs of early onset heart failure other than ejection fraction? And along with that, tell us what the normal ejection fraction is and where you get into trouble.
So normal ejection fraction is about 50 to 70%. That's the amount of blood that pumps out with every pump. So it's not 100%, it's 50 to 70%. And with heart failure, usually the number one symptom is shortness of breath. We could get other things like chest pain, fatigue, but usually the number one complaint is shortness of breath.
I think you may have just answered my question, but if someone has heart failure and they're asymptomatic, how do you know they have heart failure?
That was back to my lecture in class A and class B type patients, like pre-heart failure and heart failure without symptoms. Sometimes that does happen. But what we do usually in people that we haven't done any cardiac tests is we treat the underlying issues that could worsen heart failure. So that is treat high blood pressure optimally, treat diabetes, cholesterol optimally, and then always eat healthy and exercise. So that's what we do.
It's over here.
If you have atrial fibrillation, are you destined to develop congestive heart failure?
Not completely. You're not destined to have heart failure. There is an increased risk of heart failure, but some patients with atrial fibrillation never develop heart failure, but it does increase the risk.
Thank you, Doctor. Is this on? Okay, thank you very much. Question for you. There was some time ago, a few years back, there was a lot of discussion about heart failure patients in the hospital treating them. If they came back within 30 days, that was kind of a bad mark on the hospital and all that sort of stuff. Is that still prevalent? Does that still go around? Is there an effort to do that?
Yes, that is a Medicare metric. And it's one of the Medicare metrics that are used to see how well hospitals are doing in terms of treating heart failure, because sometimes it happens. It's unavoidable, but sometimes it is avoidable. And so we try to get the percentage of total patients that have heart failure to be less hospitalized over 30 days. And so yes, that's a metric. And how do we prevent that? We have them be seen in clinic in 1 week, which we do at Eisenhower Desert Cardiology very well. We make sure we're titrating the medications and they're being seen by heart failure clinic, and at heart failure clinic, they make sure you're not eating too much salt and eating more healthy and exercising. And so we do that. And so Eisenhower Desert Cardiology Center, I think we are doing a pretty good job of reducing the total percentage of 30-day rehospitalizations, but it can never be zero. It sometimes does happen.
How much of that grading is part of it, the patient compliance of let's try it and let's do better. And if they don't do better, how does that fit into the equation?
Yeah, it does fit into the equation. And so it is a shared decision making between patient and doctor. And the patient has to be willing to do the things that are necessary to not be hospitalized and to feel better. And so people that don't do that, they are hospitalized more at a higher rate. And so that's why we encourage our patients to be active participants in treating their heart failure.
Another question, what symptoms lead you to hospitalization for BHF?
Usually it is shortness of breath, but hospitalizations and not being hospitalized is just like any other medical issue. For example, if you have pneumonia, if the pneumonia is bad enough, then you have to be hospitalized. And most people can tell they need to go to the ER if they have pretty bad pneumonia. But some pneumonias, they're not so bad. And so they go see their doctors in the clinic and they are not hospitalized. But in heart failure is the same. And it mostly comes down to shortness of breath, some fatigue and weakness, but the patient can usually feel that they're not feeling well enough that they call 911 and go to the hospital. And that's when you get hospitalized for congestive heart failure.
No. Thank you. We're talking about shortness of breath from, say, AFib or whatever. What can you do? You talk about not going to the hospital for it, but what can you do in your normal life to help you with that shortness of breath?
So most of the treatments that we talked about are both in the hospital and not in the hospital. So we could do the things that we've talked about in this lecture at home and in the clinic. And so if somebody comes in with shortness of breath, then we do tests like an echocardiogram. We look to see how the heart's functioning. And we tell them you have to eat less salt, you have to exercise, you have to eat healthy. And then we start them on medications also.
I have another question. And you talked earlier on about the fight or flight mentality from 2 million years ago or so. And we still have that within us, you said. But what about, and because the heart is working harder in that flight, that's not good. Well, how does that compare to somebody that's been in athletics all their life? And they've, of course, with the heart being a muscle, it gets large and enlarges just like your arms or your legs. To get you more blood into your heart. And as you get older, your arteries get thinner. And so there could be a problem there. I was diagnosed with an enlarged heart when I was in my 40s, but they had later in life said that it had reduced back to its normal size, except one of the main valves didn't, it remained larger than normal. And that's what they had. I ended up having what they call a leaky valve. And I'm just wondering, is too much exercise where your heart is really having to work all the time, is that not good for you?
What we found is a normal amount of exercise doesn't seem to make too much of a difference, but there could be too much exercise. And these are like frequent marathoners and ultra marathoners. There is an increased risk of heart failure into the future. It's not a guarantee, but there is an increased risk.
Thank you.
Dr. Choe, thank you very much for this great lecture. A lot of information there. It shows what a difficult subject heart failure is. I think it's very difficult. People say it's and this ominous thing. You say you got heart failure. Well, you're going to crap out in a couple of days or something. No. But it is kind of ominous. And how do you sort of say, well, it's not so ominous? Here's the things you can do. How do you counsel a patient like that?
That's a great question. The name heart failure, whoever named this disease named it something really bad, sort of like heart attack. And I guess in the end it could be like that, but what we see is as we get older, when I do an echocardiogram, there is age-related abnormalities. And could I call it very mild heart failure? Yeah, I could, but we usually don't because it sounds bad. But there are just age-related abnormalities, and most people, they live with these mild age-related abnormalities, and they won't have any problems ever to the end. But it's a degree kind of a thing, and once you hit a certain degree, then we call it heart failure. But it is a bad name, and people do really react to this name called heart failure. But that's the name, and so we keep on using it. And but when I look at these echocardiograms, I would say everybody by the age of 50 has just a touch of heart failure. But we don't call it heart failure. We just call it stiffness of the heart. Grade 1 diastolic dysfunction, we call it. But there are much better treatments now. And so even if somebody does have severe heart failure, we can have people live longer with these treatments.
Let's give it, Doctor, a really great hand. Thank you so much. Appreciate it. Thank you. Please sit around here for a few minutes. Thanks. Before we close out the Zoom and while you folks are here, we're going to go into a second part of this. We'll have about a 10-minute break, and then we can all assemble. We'd like to know some of you people that are new for the first time here with us. How can we help you? The people in the white jackets around here, and there are more than that. Some of them came in incognito and civilian clothes tonight, but they are the accredited visitors to go around the hospitals and here and over at Desert Regional. So we'll sit around and talk. We'd love to hear your story and see how we can help. Our next session that we're going to have will be on March 14th. And Dr. Wicks, whose real name is Dr. Shanaka Wickramasinghe, I only know that because he's my doctor, because everybody calls him Dr. Wick, right? Everybody calls him Dr. Wick. He's going to talk about venous ablation, something kind of new around here, and that subject will be on Zoom as well. You can register on eisenhowerhealth.org, the calendar, and we hope to see you here either in person or on Zoom. I'm also very excited to tell you that our chapter over many years has tried to raise funds for cardiac nurses scholarships. And we've just now got to the point where we now have money in the pot to be able to award those scholarships. And we have the announcement will be going out to the nurses here in the hospital and over at Desert that would like to become cardiac nurses in a bachelor's or master's program. They have to be enrolled in it, but we'll get that information out shortly, and they can apply, and then we'll give out some scholarships, and we're very happy to do that. Over time, we've done about $20,000 over time, and I think we have about $5,500 in the pot now. So that was our threshold. So we're really excited to do that. I also want to thank Lydia Vincent, our medical director here, who was an RN here, chest pain coordinator, and she brought Jackie with. And Jackie, I forgot your job. What was that? That was her job. Heart failure program coordinator. Well, you're perfect for tonight's here, right here. Yeah. And Brett Kleiner is our man over here. We're operating the Zoom and our primary partner for putting all this kind of stuff on too, along with Lydia. So we give those folks a hand too, please. So we're going to close down Zoom at this point, and we would like you all we're going to take about a 10-minute break. At this point, Doctor, you're welcome to go to the healthy table over here and either you can have one of those wonderful cookies or a brownie or some of that broccoli. I don't know what you want to do. So anyway, so we're going to we'll break at this point, and please stick around, have some refreshments, and we'll sit around and talk about stuff. Thank you.